The aorta, the abdominal aorta, 3 unpaired vessels. The celiac we did yesterday. Today we're going to do the superior mesenteric and the inferior mesenteric. There's a 4th unpaired vesicle. It's called the median sacral. Just runs right over top of the ventral aspect of the sacrum. Everything else is paired pretty much. You have inferior phrenics, and there was a couple of cadavers yesterday. We found the inferior phrenics. Below them, you're going to find the very large renal arteries. We'll talk about those more later on. You have segmental arteries that go to supply the abdominal wall musculature. These out here. You have the gonadal arteries, either ovarian or testicular, that come off of the aorta. Note that the left gonadal artery comes off higher than the right. The left one will be about a ½ an inch from the left renal artery. And the right one is just a little bit lower. And then the aorta bifurcates into the right and left common iliacs. And we'll deal with the iliacs when we do the pelvis and perineum next week. All right, so here's the summary of the superior mesenteric artery. The superior mesenteric artery, we said yesterday, if this is the C-loop of the duodenum, the pancreas sits right there. There's the superior mesenteric artery. It's going to be coming right through it. It has 10 to 14 intestinal branches that will go to supply the entire small bowel. The entire small bowel is supplied by the superior mesenteric artery, except for the part of the duodenum that was supplied by the celiac that you did yesterday, right? Okay, now, then the superior mesenteric, if you lay out your large bowel like this in the cadaver, it'll be easy. So what you want to do is you want to take the small bowel and move it up to the left upper quadrant. And there's the superior mesenteric. Very easy to find all these vessels. It's take you no more than 5 minutes. All right, so there are branches I want you to know. One of them is this large one right here called the ileocolon. Goes to the ileum, terminal ileum, and to the cecum. It also supplies the vermiform appendix, or appendix. Vermiform because it looks like a worm. You have other appendices in your body. So to distinguish this one from the other one, this is actually called the vermiform appendix. All right, now you got a right colic that goes to the ascending colon. You got a middle colic that goes straight up to supply the transverse colon right there.
The middle colic does
It goes up to supply the transverse colon. Now if you take a look at the inferior mesenteric artery, it's right here. Now to find the inferior mesenteric artery, if you'll take the bowel and shift it over to the other side, then there's the inferior mesenteric artery, because it's getting the descending colon via the left colic artery. It has about 4 branches that get the sigmoid colon, called sigmoidal arteries. And then the last branch here, right here, you go to the very end of the inferior mesenteric, the last branch that heads off down to the pelvis is the superior rectum. Now, all of these arteries are connected by an artery that runs along the margin of the large bowel called the marginal. You just call this entire thing the marginal artery. The one that runs parallel to the organ itself. And they're all connected. The branches of the superior and the branches of the inferior, they're all connected. So you've got a nice anastomotic loop around the small bowel. Oh, excuse me, the large bowel. Now, there are some weak spots where the vasculature is the thinnest, and that would be up here in the splenic flexor, down here in the sigmoid region, and over by the iliocolic portion, where these stars are illustrated.
What was the last
The
one?
Iliocolic junction. In terms of the blood supply coming from two directions, those are the weak spots. Okay? That's it, we're done.
Yay.
Okay. All right, this is the ligament of Treitz I mentioned yesterday that holds up the small bowel. This is the duodenum as it comes across. It's attached by this connection to the diaphragm called the ligament of Treitz. Right there. Ligament of Treitz runs behind the tail of the diaphragm, pancreas. I want to throw that in there because I remember I had a slide.
So you called, I'm going back, sorry, the whole thing, the marginal?
Yeah, the marginal artery is just the one that runs, pick a point, doesn't matter. It runs the entire length of the colon.
Okay.
And it's just the one that parallels the inner inside of it.
What's the sweet point, the third lowest on the?
This one right here, it's at the rectosigmoidal junction.
What's this? Will this be called the dorsal mesentery as well, or that's only in the foregut?
No, this is all dorsal mesentery. Yeah, and it's all going back to one place. That's the root of the mesentery. What? Like you understood something?
Yeah.
Like, all right, I got it. It is dorsal mesentery. All right, so now when we get down, now this is what I don't want you to do. When we get down to the lab, there are going to be variations in this. Okay? Here's Dan's rule of colic blood supply.
Oh boy.
If it goes down to the iliocolic area, it's the iliocolic artery. There may be two of them that go down there. I'm going to call both of them the iliocolic artery. If it goes that way, I'm going to call it the right colic. If it goes that way, and it's the only one going that way, I'm going to call it the right colic. If there's one going that way and one going that way, I don't give a rat's ass which one you call the right colic. That one looks sort of rightish to me. I'm going to call it the right colic. So there's a lot of variation in this. Don't ask me, is this the right colic? Is it going to the ascending colon? It's the right colic. I'll give you that. Okay? All right. Nobody will miss that on the practical. Woo! All right?
Well, beyond.
So you got one right. Yeah, like last night I was watching, because our internet's been out since Friday. I told you about that, right?
Yes.
So it wasn't fixed last night. So it was on, what was that show where the people lose the weight? Biggest Losers, Fat Losers or something? So this lady, she got a pound. She won some kind of prize, and she got a pound that she could use in the weigh-in. And her trainer told her to save the pound. She might need it later on, right? She didn't use the pound. She lost the weigh-in by 1 pound, got her ass booted from the show with that pound in her hand.
Wow.
Doesn't that suck? All right. There is a way you can tell whether or not you're dealing with the jejunum or the ileum. Remember I said the other day, if you draw a line, that's jejunum, that's ileum. Well, there is actually an anatomical way you can do it without having to look at a histological slice. And that is if you look at the blood supply coming off of the intestinal arteries. Remember the 10 to 14 intestinal arteries right here? Okay, those intestinal arteries form arcades. In the jejunum, the arcades are small. And the windows are large. In the ileum, the opposite is true. You have large arcades in the ileum and small windows, or vasa recta, that make up the windows. You see that? A detail of the ileocholic artery, because this is an important artery in general surgery. It comes down and branches into an iliac branch, or a branch going to the terminal ileum, and then a cecal branch. The cecal branch has an anterior-posterior aspect that supplies the front and back of the cecum. And then also there's an appendicular branch that comes off of there that supplies the appendix. So those are the four branches of the ileocholic. The appendix, the appendiceal, the ileo branch, and the anterior and posterior cecal branch. This is an interesting thing here. Atrial fibrillation is a disorder where the atria sit there and quiver. They don't have an organized contraction. They quiver. Most people who are elderly, not most people, a lot of people who are elderly will be in AFib. It's just a normal part of, almost a normal part of aging. The problem with atrial fibrillation is that when you don't have a nice organized contraction, blood can tend to get stagnant in the atria. And when blood stagnates, what happens to it? Clots. So clots can form in the atria. Most of the time they form in the articles, those little ear-like appendages, because that's where blood just doesn't flow very well. So if you're on the left side of the heart, in the left atrium, and one of these clots breaks free and goes through the left ventricle and out the aorta, one of the places it can go is up the carotids to cause a stroke. The other thing, it can go into the coronary arteries, which usually doesn't happen. It can go to your renal arteries, or it can go into one of the mesenteric arteries and cause a blockage of one of these large arteries supplying the intestines. That produces, if it's small bowel, see, small bowel doesn't have the collateral circulation that the large bowel does. If it's small bowel, you can wind up with mesenteric ischemia. It's an acute onset, horribly painful abdominal pain that is out of proportion to the physical findings. They come in right away because they're in such horrible pain, but you have no fever, you have no white count. I mean, it's just, you know, that something's not adding up here, but you're in excruciating pain. That's the pathognomonic thing for mesenteric ischemia. Pain out of proportion to physical findings. If you ever see that on a written exam, and you probably see it on your board exam, the answer is mesenteric ischemia. Infarcted small bowel. The question here that's posed on this thing is, why would a mesenteric ischemia not be due to an embolus from a clot in a leg vein?
It's not going to go through there.
Where would it go?
It would go back up through the IVC.
To where? Where is the capillary bed from a leg vein?
The lung.
The lungs. A DVT, a deep vein thrombosis, would embolize to the lungs. It's going to get trapped in the lungs. It's got to be on the left side of the heart for it to go up to the brain or to somewhere else in the body. What congenital defect would a person have for a DVT to embolize, so now it's moving, this clot is moving, to produce mesenteric ischemia?
Put it in the artery connect.
An AVM?
Yeah.
No.
What's the problem?
Patent,
Could it be the
the arteriosum, or the.
Yeah, the ligamentum
Ligamentum
teres.
arteriosum.
That would work, a patent ductus arteriosum, or a patent foramen ovale, or some other place where you can have a right to left shot of blood. Right? Correct? Everybody understand that? If you had a patent foramen ovale, you get a DVT coming up, enters your right atrium, crosses over to your left atrium, left ventricle, boom, it's out now into your intestines. I knew a kid, an 18-year-old kid, stroked out from a fat embolus. We'll talk about this next 2 weeks or so. He had a fat embolus from a broken femur, wound up stroking out and died. How in the world did that happen? Turned out on autopsy, he had a patent foramen ovale. Man, you're talking about bad luck. Okay, 18 years old. Here's a picture of infarcted bowel. This is not what you want to have. Of course, that has to be resected, cut out, and put into end anastomosis of the bowel. Venous drainage of the intestines. Ooh, this is a biggie. Okay. All right. So we know that the superior and inferior mesenteric arteries in the celiac go to supply arterial blood to the GI tract. They're going to pick up all the nutrients and all the toxins and all the vitamins and everything you take in through the capillaries in the intestines. Those capillaries reform into veins that take all of that garbage to the liver, where they break up into capillaries again within the liver. That's the definition of a portal system. You found a portal vein yesterday. A portal system is a vein connected on each end by a capillary bed. So this is the hepatic portal vein right here. It's formed by the junction of the superior mesenteric and the splenic vein. There's the splenic vein, superior mesenteric vein. Some of you guys already found those yesterday. Now keep in mind this. Here's the superior mesenteric vein. Here's the splenic vein right here. Here's the portal vein. The inferior mesenteric vein will join this somewhere along in here. Most of the time it's right there in the middle, but it can be anywhere along in there. So the inferior mesenteric, the superior mesenteric, the splenic, all combine to form the portal vein. It's taking that blood, that deoxygenated blood, to the liver for processing the nutrients and stuff, for detoxifying. Oh, I thought you had given up on taking notes. So, all right. Now, here's the thing. There are places, so that you call this the portal system. Well, we know we've got the inferior vena cava, right? That's another whole system. The vena cava system, the caval system, drains the body walls and the limbs. You know, the arms go into the superior vena cava, right? Legs are going to eventually join to form the inferior vena cava. So we've got two separate venous systems, one caval, the other's portal. There are places where these two caval systems connect. They anastomose. 3 places in particular. Around the esophagus, there's the left gastric vein, there's the esophageal vein. So right there. The blood on the caval side, you see, goes into the azygous system. Where does the azygous drain? Into the superior vena cava. Remember, I told you before that there was a connection, an inferior connection to the azygos. This is the importance of that. You have a portocaval anastomosis right there at the base of your esophagus. You also have a portocaval anastomosis around your belly button. Remember that kaput medusae thing I showed you before? You're going to see it again today. So you've got these para-umbilical veins that drain into the cable system, and these drain up into the portal system. You're not going to find either of those in lab.
Which one is the?
This branch is going up to the portal system here. Okay. There's anastomosis between the lumbar arteries off of the aorta. You know that I showed you the lumbar arteries off of the aorta. You have lumbar veins coming back into the inferior vena cava. That's what these represent. And you have cable veins, portal veins here along the intestines. This area right here is not so important. The other one, though, that is important regarding the intestines is right here around your rectum and anus. You remember you had the superior rectal artery coming off of the inferior mesenteric? Inferior mesenteric? Let me go back and show you. Whoops. Right there, superior rectum is the last branch off of the inferior mesenteric. Okay. You have a superior rectal vein that runs with it. That superior rectal vein is going to drain into the inferior mesenteric vein to go cable, to go portal. Also around your rectum here, branches of the internal iliac that we won't see until next week. The internal iliac drain the rectum. You have middle and inferior rectal veins. Those are cable. Anything that drains into the inferior vena cava is called cable. So superior rectal vein is portal, middle and inferior rectal vein, cable. In addition to being a vein with a capillary bed on either side of it, portal veins are characterized by they don't have valves. If you have valves, we know that veins have valves because you saw it at the inferior vena cava. There's a valve right there, right? You have valves in your legs, otherwise blood would pool during diastole. You know, your blood would pool in your veins. The veins have valves. Portal veins do not. That means that blood can flow in either direction in a portal system. We talked about cirrhosis blocking the blood flow through the liver. So now you have all this portal blood trying to get through the liver. It can't. Yet you have hydrostatic pressure coming from behind, coming from the systolic pressure, pushing on it. So what you try to do is you try to shunt that portal blood into the cable system at these points. You try to shunt the blood from here into the cable system through those points. This produces varicosities at each of those locations. Big, fat, ugly, dilated veins. That result in hemorrhoids, the caput medusa, and what are called esophageal varices. I'll show it to you later on. We also talked this morning about what else happens with the liver if the liver's not working. Vitamin K dependent clotting factors are not there anymore. So these people, when these varices start bleeding, they tend to bleed really bad. And you don't have any albumin, you're not making albumin, so they're all bloated and edematous. It's just not a good situation. increased pressure in the portal system because of things like cirrhosis or hepatitis is called portal hypertension. And what you can do is you could go in there, let's increase the portocable anastomoses. Let's take the pressure off the portal system. Let's take the splenic vein, remove it from the spleen, and tie it into the renal vein. And that's one way to dump portal blood into the cable system. You take the splenic vein and put it into the renal vein. That's called a splenorenal anastomosis, or a portocable shunt. Once you are so bad that that has to happen, you probably bought your last pair of shoes.
This may be a really silly question, but how does blood leave the spleen then?
I'm not sure what they tie into. They probably just do a splenectomy, take the spleen out. That's what I do. So, okay? At that age and in that condition, you're not going to need it. Here's the caput medusae that you've seen before. This, the edematous varicose veins around the periumbilical region. Here are the veins that drain it. This is hemorrhoids. There are two types of hemorrhoids. And so what's going on here, a hemorrhoid is a dilated vein. That's all it is. And it's covered by the mucosa of your rectum. There are two types of hemorrhoids. There are external hemorrhoids and there are internal hemorrhoids. Either can happen with portal hypertension. External hemorrhoids, we'll talk about later, I think, because they're associated with the skin, they're in the somatic area, they're really painful. Internal hemorrhoids are autonomic in nature, and you usually don't even know you have them until they start bleeding. Or they obstruct defecation or something like that. So these are both a couple of examples of external hemorrhoids. This is esophageal varices right here. There's the normal esophagus. Here are all these dilated veins of esophageal varices. This is the one that will kill you. When these start bleeding, you can't stop it. So they come in profusely vomiting blood. And you got to get them to the OR. That's the only way to really save them. There are a couple of steps you can do. I had the worst patient I ever had in my emergency room career was a 32-year-old lady that was an alcoholic. She had two little kids, raging alcoholic. She came in one Friday night just throwing up bright red blood and from bleeding esophageal varices, and got her IVs in place, right? I'm trying to maintain her blood pressure, right? Starting IVs, 2 large bore IVs. We didn't have blood on hand. Got the helicopter there. This was up in Blackwell. Got the helicopter there. Got her flown out to Wichita, and she died on the table. So, I mean, there are a couple of things you can do. One of them is you can take a Foley that would go in the bladder, put it down. Foley has a bulb on the end that you can blow up. So you put a Foley down to the distal esophagus and fill it up, blow it up with ice cold water. So the pressure and the temperature will help put pressure on the bleeding, but it usually doesn't work. They usually have a very high mortality. Very high mortality. All right, Karen.
Like, are they dying because they're bleeding out?
Yeah, she exsanguinated. She died. That's how she died. I mean, she exsanguinated to a point she went into cardiac arrest. That's how she died. Cardiac arrest. PEA. At some point, she was in PEA. I can guarantee you that. Okay, how do you know you're looking at the colon? The colon has three characteristics. One is, who was that asking me? Not today. You were asking about the inner circular outer longitudinal muscles. That's how it is in the small bowel. In the large bowel, the outer longitudinal muscle is clumped into three bands. So these bands are very obvious. That's the outer longitudinal muscle right there. Because it's in a band and not wrapped all the way around it, it sort of scrunches it like a curtain into these things called hostra. That's why your doo-doo has lumps in it. You have the hostra. The bands are called tinea coli, and there are three of them. Around, like every 60 degrees or every 120 degrees in the colon. If you want to find the appendix, which is sometimes hard to do, find the tinea coli and follow it down to the base of the appendix. That's how you find the appendix. If you get lost.
Base of it?
Yeah, at the base of the appendix. That's where the appendix will be, where these three bands come together. That's the appendix. So hostra, tinea coli, and these fat globs that hang off of the bowel called epiploic appendices. Somebody was asking me yesterday what these fat globs, I said, well, I'll tell you tomorrow. That's what they are, epiploic, was that you got? Epiploic appendices. I didn't want to say it yesterday because it's like a 26-syllable, 2 words, epiploic appendices. I don't know why they're called epiploic appendices, I have no idea. Where you find the appendix, most of the time the appendix is tucked up behind the cecum. And then it's found in various other positions. Sometimes during surgery, this thing can be really hard to find. But most of the time it's going to be behind the cecum. That's why, because it's down here in the right lower quadrant, that's why in females, I think I mentioned the other day, if they come in with right lower quadrant pain, you need to do a pelvic exam. Because that can, if you're in that area, it's going to be painful if they have appendicitis. Okay? Innervation of the viscera, we've kind of been over this, and it's the same for the bowel as it is for the liver, the stomach, the gallbladder that we talked about. You've got the vagal trunks, the anterior and posterior vagal trunk. The anterior vagal trunk is on the anterior part of the stomach and distributes primarily to the stomach. The posterior vagal trunk sort of gets everything else. Down to, where does the vagus stop? Splenic flexure. From the splenic flexure down to the anus, or down to the distal rectum, it's supplied through S234 that comes up through the hypogastric nerves. Today you'll see the hypogastric nerves off of the aorta. It's a pretty nice plexus like that around the aorta. There are some, and you might run into the lumbar splanchnics. These are like thoracic splanchnics. They come off of the chain ganglia. They provide sympathetics to this ganglionated plexus. I mentioned either yesterday or today, I'm not exactly sure when, Hirschsprung's disease, aganglionic megacone. Was that this morning that I talked about?
Yesterday.
Yesterday? God dang, man, I have got to get away from this planet. So here are the cell bodies are located between the muscle layers. You kept asking me about the muscle layers, so there they are. All right, retroperitoneum. Retroperitoneum, what we've done is taken out the intestines, and we don't actually want to take out the intestines today. You can just move the small bowel to find these structures. All right. We talked about primary and secondary retroperitoneal structures yesterday. Here's a list of which ones are which. Basically, the easy way to remember this, urinary system and the adrenal glands are primary. Whatever else is asked, if it's retroperitoneal, it's got to be secondary. Okay? Huh? The spleen is actually within the it has a mesentery and hangs off of the dorsal mesentery. It's free. Yesterday, I pulled a couple of the spleens. You can reach down in there and pull them up because they're connected to that mesentery so well. Even though they're way back here on the back wall. All right, abdominal aorta and inferior vena cava. This is some anatomy you need to appreciate. You need to know this, actually. The aorta is on the left. The inferior vena cava is on the right. The reason you can remember that, and it took me a second because I had to go back to the way I remember this, is that in pregnant women who have this great big uterus during the third trimester, if they're in cardiac arrest or anything like that, where they're unconscious, you want to put them on their left side. That shifts the uterus over to the left and takes pressure off of the inferior vena cava that's on the right. Note that the renal vein, the left renal vein, crosses in front of the aorta. Note that the right renal artery would cross behind the inferior vena cava. You may hear these referred to as big red and big blue when you're in the OR. If they say, don't touch big red, stop what you're doing, because that's a big structure.
So the left renal vein crosses in front of the aorta, and which one?
Yeah, right here. The left renal vein crosses in front of the aorta. The right renal artery crosses behind the inferior vena cava. Notice also where the gonadal veins drain. The right gonadal vein drains into the inferior vena cava. The left gonadal vein drains into the left renal vein. The right gonadal vein drains into the inferior vena cava. The left gonadal vein drains into the inferior vena drains into the left renal vein. Lymphatics, this is, we've talked about this 9,000 times. The structure here is the cisterna chyli. It's located just below the diaphragm. I can't see it because of where I am, but it's located right in this area right here, just above the celiac trunk typically. That's where the lymphatics that drain the lower extremities and the intestines start. That's going to give rise to the thoracic duct, which is going to drain over here into the junction of the left subclavian vein and the left interjugular. Okay? Organs of the renal system. If you look at the kidneys have an enormous amount of fat around them. There's two layers of fat that are separated by this renal fascia. The renal fascia is a covering that's continuous with transversalis fascia laterally and the psoas muscle fascia medially. It's a tight fascial plane that has fat on the inside and fat on the outside. These fat layers are called peri and paranephric fat. peri and paranephric fat. Peri and paranephric fat. On a CT exam, here we have the kidneys surrounded by the fat. That line right there is going to be the renal fascia. That line is the renal fascia. You can also see the vessels going into and out of the kidneys right there. The kidneys are located in what are called the CVAs, costovertebral angles. This is your CVA right here. If you have kidney infection, then you want, the physical exam maneuver you want to do is you want to hit on the kidney right there. You want to hit the CVAs. You need to say CVA non-tender by that. No CVA tenderness. That's one way to distinguish between, is it just a cystitis, burning when you pee, or is it up in your kidneys yet? There are many other ways, but that's an easy, a first start, good start. Okay? The anatomy of the kidney, where the vessels enter and the ureter exits is the hilum. If you look at the renal artery, notice that it distributes along several smaller arterioles into the different parts of the kidney. The kidney is highly vascularized. Here's something kind of interesting in case you're on Jeopardy. Your cardiac output. Let's take your entire your stroke volume from a systolic contraction. Where does it go? Where does that blood go? How is it distributed in your body? Well, I'm going to tell you. A fourth of it goes to your brain. A fourth of your cardiac output goes to your brain. That means your brain is pretty significant. It does not tolerate a decreased oxygen, amount of oxygen from a decreased cardiac output. A fourth of it goes to your intestines through those celiac, superior and inferior mesenteric arteries. Well, that's 30 feet of stuff. That's a lot, right, to supply. A fourth of it goes to your kidneys. A fourth of your cardiac output goes to your kidneys. That should tell you how many times a day your blood is filtered. A fourth of your entire cardiac output goes to two little organs that are that big, that don't even think like your brain. Truly impressive. That means that leaves a quarter of your cardiac output to go to the entire rest of your body. That's pretty impressive, huh? I think it's pretty impressive. All right, the structure of the kidney, what you want to do is take out one kidney and cut it open so you can see the internal structures. The kidney is made up of these pyramids. Between the pyramids are columns. The cortex is out here. This is where you'll find the glomeruli, if you remember the renal histology. Down in the pyramids is where you're going to find the loops of Henle and the other aspects of the collecting system. These guys open into these little areas right here called the papillae. The papillae have little holes in them there. You can see that they open in, that's where the urine comes out, into the minor calyx. You have about a dozen or so minor calyces that drain into about 4 major calyces. The major calyces drain into the pelvis. The pelvis drains into the ureter. That's the structure right there. Pretty simple. Want to go through it again?
Yep.
Okay.
You're on crack all the time.
What are you taking?
I told him at lunch today, I said, you people think I talk fast.
Oh my Lord.
Reinhardt, Fetters, they all said, no, you talk like you're on Quaaludes, you know, when we would listen to you, we had to speed you up two times.
They're lying.
I said, I don't know what is the matter with you people. Y'all gotta keep up.
They're lying to you.
No, they were talking bad about you. I can't wait till you see me in my shoes on Saturday. All right. Arterial blood enters the kidney, goes to the glomeruli, urine is filtered. You understand the nephron, right? The glomerulus and the loops of Henle, and you remember all that? You're gonna get it again when you get to physiology. But needless to say, the blood is filtered, and the urine collects in here and drips out the little papillae, the holes in the papillae. And it collects into this space here, which is the minor calyx. You have about a dozen or so minor calyces. 3 or 4 of them will drain into what's called a major calyx. So you have maybe around 4 major calyces. The 4 major calyces drain into the pelvis. From the pelvis, it gets into the ureter.
What does a major calyx do?
It's just a collecting system. If I'm the major calyx, I have minor calyces here that are attached to the papillae. So urine enters my arms, comes down to me, I'm the major calyx, and then out my leg, which is the ureter. Understand that the ureter, this is not a passive system. Urine doesn't just flow. Once it enters the ureter, there's actual peristalsis of the ureter to propel urine towards the bladder. That's the pain of a stone. You get a stone lodged in the ureter, and you're trying to peristalsis against that stone, it produces a rhythmic pain. In this illustration here, it's showing the 2 ureters, their course down into the pelvis. Understand that the right ureter travels behind the right gonadal vein, and then both of them travel over top of the common iliacs. Not under them, but over them. In the female here, here's the uterine artery. The ureter travels under the uterine artery to enter the backside of the bladder. In the male, and we're looking at this male from behind, so his pee-pee goes that way, right? We're looking at it from behind. Here's his prostate, there's his bladder, here's his seminal vesicles. The ureter goes up underneath the vas deferens. This relationship, don't worry about this relationship for this test. This is the next test material, but I wanted to, you needed to follow it to see what it looks like when it gets into the pelvis. Okay? You can have all sorts of variations to the kidneys. Matter of fact, 10% of all people are born with a significant congenital anomaly of your urinary system. 10%, 1 out of 10. That means 3.6 people in this room have a significant anomaly in your urinary system, and you don't even know it. Okay, this is one anomaly here, a bifid ureter. You can see when they put this contrast material in the artery that gets picked up by the kidney and filtered by the kidney and is in the collecting system now, this person has 2 ureters. Kind of cool. The renal autonomics, basically it's, I want you to consider the renal autonomic just like the gut autonomics. You got parasympathetics from the vagus, you got sympathetics from the pre-aortic, you've got the renal ganglion providing those sympathetics. Keep in mind that the renal arteries, because they are carrying 1/4 of your cardiac output, if they're too constricted or too dilated, it really has an effect on your blood pressure. I'll give you two examples. One of them is renal artery stenosis, which is essentially calcification or atherosclerosis of the renal arteries. That is a cause of hypertension. If 1/4 of your blood is suddenly having to squirt through two sclerosed down arteries, your systemic pressure is going to go up. Remember, your hydrostatic pressure in the resulting vessels is going to go up. The other thing is, we talked this morning about dopamine as a sympathomimetic to increase your blood pressure. Remember we said that? The dose of dopamine that is normally used is 5 to 20. You don't need to write this down. 5 to 20 micrograms per kilogram per minute. That's the dose that you would put in a drip. 5 to 20. That will constrict blood vessels, raising your pressure. If you use a dose less than 5 micrograms per kilogram per minute, it has a tendency in some people to dilate the renal arteries. If you dilate the renal arteries, what's going to happen to blood pressure? It's going to drop. So your intended purpose to increase blood pressure just went the other way, like these monitors. Okay? I think somebody's telling us that it's time to take a break.